in elementary school all the way up until high school. Like you want to educate early on so that people recognize the signs of stroke. So like any app that will promote that will be useful.
So that might improve the casserole effect, or?
So unfortunately, stroke exceptions don't hurt. It's not like our cardiologist believes that it's not hurt, they're going to go to the emergency room. Most of the people will sleep over hoping they're going to feel better next day. Anything that improves education, anything that brings the level of awareness that a stroke can be that symptom, sometimes they're very hard to diagnose for the trained neurologist. That's why, because it's a clinical diagnosis, you will not ever have a pre-hospital stroke scale that is going to be accurate enough to rival an EKG or a sticking bone that is broken. So we have to rely on education. Education, playing the odds. If you have 70% rate of detection in Cincinnati, my God, take it. You know. Now the question is, how many of those people will have a large vessel occlusion? Is it 10%? Is it 30%? Is it 40%? So you play the odds, and you say, I'll do everything I can for this patient to get the best outcome, playing these odds and the tools that I have at this time. 5 years from now, 10 years from now, every ambulance is going to have a mobile CTA, and we're going to do CT in the field, so be it. That's going to be great. That's going to be how we're going to diagnose every and each one of the strokes. Until then, we use what we have. The only pre-hospital stroke scale that was validated prospectively, not retrospectively, prospective, so it's race, and it has its flaws, but I'm not endorsing any of the scales. Whatever you use, whatever you're comfortable with, so be it. But that was the debate of what's the best. The race so far is it's okay.
Dr. Atkinson.
One comment on the app, and Chuck's not here, right? He's gone.
Right, yeah.
So I would hope he, I wasn't going to say anything like that. I would like to know if he's collecting data on the accuracy of the use. Because when you realize there's an app on your phone and you're a hypochondriac or something, your kids may start punching it, you may butt dial it, who knows what can happen. And I apologize for that. And I just wonder whether you could overdo the 911 thing by, you know what I'm saying. And so I hope he would collect data on the number of times that app was used and what the outcome was in some way. I don't know if he could do that.
I know he's working with Stanford, so they're probably collecting some data. Betsy Thompson, Dr.
Well,
Betsy
this
Thompson.
follows up this same sort of thing, really, is that I think the app's a great idea. It seems to be a great idea. There have been a lot of great ideas in public health that we've all been party to, or at least I've been party to, that a lot of money and time and energy was spent that turned out to actually, in reality, not have the impact that was desired. So I'd say it's a great idea to pursue, but I didn't hear much about evaluation, and so if you're going to do that in Sacramento County, I would say really take advantage and evaluate, is it truly effective? It can also, the danger of sometimes of education only is that you almost get a false sense of complacency that you know, we've got this taken care of, when in fact it wasn't.
Okay, we'll go left to right. I think that's
I wanted to add to that, and another thought I had for saying at the end, but I think that was a timely time to say it, that I agree it has potential benefit, but I really think it should be part of a comprehensive education and prevention strategy. And the comment I was going to make is that seatbelts and crumple zones and mothers against drunk drivers have saved more lives, trauma lives, than trauma surgeons have. And so I think like education, awareness, and then prevent blood pressure, diabetes, smoking, you know, from the public health side would save more lives. And I'm an emergency physician, I do emergency care too. We're going to have plenty of business still. But I think the most effective change is if we do bring in that app into Sacramento, there should hopefully also be tied in with things that we know are effective from the public health standpoint, which is education and prevention.
well, any questions? Yes.
Yeah, sorry, just a clarification for Mike Pelosi and Regional Stroke Coordinator from Kaiser. Question for Dr. Megan? Anyway, Megan, so I know that Dawn stopped early. Are you saying that diffuse is also stopping early for efficacy?
Yeah, we don't enroll at this time any patient. They are doing the preliminary analysis. hopefully it's gonna go further because the inclusion criteria is slightly different from Dawn. It
Yeah.
looks at the bigger core infraction, 70 mLs versus less than 30. Anyway, so we are hopeful that we're gonna involve. But yes, they're looking at the data. There are 2 other studies looking at beyond 6 hours, which we'll publish later on, hopefully this year.
So last question is, TPA was very effective in STEMIs for years. It's largely gone away for STEMIs because we do entirely interventional. Do you see that direction proceeding with strokes, and eventually we might prefer to do an intervention and avoid the possible complication of increased bleeding or intracerebral bleeds associated with plasminogen activator?
The answer to that is no.
Okay.
It's like thrombectomy is very specific for specific groups of patients. Patients with large vessel occlusions, meaning an ICA occlusion or an M1 occlusion. And there isn't data that suggests that occlusion beyond the M1 segment or the first segment of a large vessel, that it's helpful. That may change in the future. Like I said before, stroke is a moving target, depending on our technology and what happens in the future. But when we think about the majority of strokes, which include subcortical strokes, distal cortical strokes, TPA is our best option up front. So that's never going to change. So there may be better options, in terms of thrombectomy agents in the future, but in terms of that first line option out there, that's going to be the best option for every patient that comes through the door with the stroke in a 4.5-hour time.
Thank you very much. We are out of time for this section, so we'll move on to the next. I would like to sincerely thank the 4 panelists for their time.
Thank you, Dr. Palmer, for leading that excellent discussion. So I know this has been a long afternoon, and we want to thank you for your participation, but I want to introduce Mr. Vic Smith, who is with the American Heart and Stroke Association, and his topic is American Heart Stroke Association Sacramento Quality Improvement Activities and Resources. And Nick has recently joined the American Heart and Stroke Association here in Sacramento as the regional director, and he is responsible for quality and systems improvement in Northern California, Oregon, and Northern Nevada, so that's a huge area, and really has been instrumental in working with getting with the guidelines, and has worked in areas of stroke, heart failure, and resuscitation, as well as atrial fibrillation. So thank you for being with us.
So obviously, one of the tough things about going last is you hear all that great conversation, and your bullet points kind of get all blown up there. So I just wanted to just quickly mention a couple of the things or the ways that we as the American Heart, American Stroke Association are kind of involved in this discussion here today. One of the things that we do is we put a lot of time and energy into creating resources for patient and community education. In my role, primarily as was mentioned, I'm with the Quality and Systems Improvement Program, and one of the main focuses of that is our Get With the Guidelines programs, which are really designed to help hospitals take current guideline recommendations and apply them to how they treat the stroke patients that come into their facility, and really be able to measure that care. And then we provide kind of ongoing support as well to work with their teams, to just kind of talk through any obstacles they might encounter, and really also highlight the great performance that they do. And we're very fortunate, obviously, here in Sacramento to have some great hospitals that are providing some great stroke care. The the educational pieces I'm talking about, and they're available for everybody. So I try to make sure that the hospital's aware of those. And additionally, for groups like this, we definitely want you to know that there's some great resources housed on our website, that are just really fantastic in terms of helping create broader education around stroke, as well as for post-stroke patients and things of that nature. There's also an online support network for patients that have suffered from stroke, just to create a little bit more of a community so that they can get tapped into some of the other resources there. Really, I guess what I would highlight today as well, and I'm just going to backtrack, and I know Dr. Ng kind of mentioned it a little bit around Mission Lifeline. And so we've had a program for actually several years now called Mission Lifeline that's specifically focused on STEMI care. And really it was developed because we saw hospitals getting pretty efficient at door-to-balloon treatment times. So basically from the time that patients came to the hospital to the time that they got the procedure that was needed, was continuing to rapidly improve, really around the big door-to-balloon or B2B initiative, which a lot of you are probably familiar with. Mission Lifeline was developed because, in the context of Mission Lifeline, we want to be looking at systems of care. And really, as was highlighted today, it's a really important component. So receiving great care when you're in the hospital is extremely important, but also receiving great care leading up to the time you get to the hospital is also important, as well as looking at, that continuum of care, as we would call it. And so Mission Lifeline was developed to really start measuring what's the first medical contact to treatment time. So really expanding out beyond the front doors of the emergency room and really starting to look at and say, beyond the treatment they get here, what was that process? How long did it take? What did it look like? Did they receive good care along the way? And really the second component of that, which I think a lot of the folks were in agreement in here today, is that we've seen great success at bringing all of the key individuals, the key institutions, the EMS providers together under one roof or at one table, and really looking at the information and trying to ask themselves collectively, what can we do to really provide the best care possible to see patients move from the time of symptom onset to treatment time in the most effective manner. And one of the components of that has been looking at, specific measures or reports. That's been kind of a key highlight. That's really used to help drive the discussion. But again, the biggest factor has just been getting everybody together to really have and to create those conversations and to organize into systems of care. So I would just kind of, my closing would be with that I think that's something that everybody has an interest in, it sounds like, as of today. And I would just really encourage, we have expanded Mission Lifeline into Mission Lifeline Stroke. It's not quite as robust today as the STEMI program is. We do have some measures around our EMS recognition program that we started. And so we're trying to create a greater emphasis in terms of looking at more information around the pre-hospital side and to really, again, tie in that whole continuum of care. So that's really all I have for you. I don't know if there's any questions around that or...
Of course, I always have a question, right? So one of the things that we identified in this room a few years ago, I think actually before you joined the Heart Association, was that when we have high-risk patients, for instance, those who've had a TIA or who have out-of-control blood pressure, very difficult to manage blood pressure, AFib, other things that make them high risk. As was said in the meeting with Pat Zrelak and Jonathan Hartman a couple days ago, the Northern California Stroke Coordinators meeting, thank you, Katharina, for putting that on. The biggest benefit is never be alone. But it doesn't work if in the case of Chuck Tennisketter, the person who sees it doesn't know what they're seeing. So one of the things that was identified here was a need for evidence-based information about, for families of high-risk patients for signs and symptoms recognition and action plans. So the difference is not general public education, but specific education for families of high-risk patients. Is there anything anyone can point to?
So you're asking me...
Heart Association, do
Yeah.
they have training programs for those who are most likely to witness that event?
You know, I would say, in terms of the things that I do day to day, what my focus would be is trying to put the resources into the hands of the folks that, you know, we do also do a lot of work with community health departments and things of that nature. So I would say to answer your question, and we also have a stroke initiatives kind of arm of the AHA, which does do a lot around community education as well as more, you know, promoting kind of groups for post-acute stroke and things of that nature, care community. So do we do anything where we're specifically targeting the high risk? You know, I think the idea is that the resources are out there and that hopefully through our various connections and the places that we go, we can get that information out there, but we don't have anything where it's like a specific. I do know there's a big initiative from a community health standpoint, and that would probably be something that would fall a little bit more on our community health initiative side to really be far more proactive in terms of not just the acute care phase or even the post-acute, but going into the community health and preventive side. I don't know if I answered your question or.
Well, I want to open the question up to you all. What do you know about training the families and those who are around high-risk patients about what to do?
So Patty, I think that some of the high-risk populations, like the that end up in a phase program, they have several chronic conditions, and so they escalate, and so they go to outpatient education classes. So those patients get, and their families get education on stroke signs and symptoms and signs and symptoms of heart attack.
Well, that's the first I've heard of this.
Yes, but if you have high blood pressure, you go high blood pressure class or something like that, it's typical to put signs and symptoms of stroke, heart attack in this site types of courses.
And are the other systems doing that?
I have, when we are getting stroke patients, the families, we will ask the family that in your family, do you have any family members with a stroke? So we will encourage the family members to go and talk to the doctor and go and CT scan or something.
We can utilize our primary care physicians to do the education for the family. Because usually when post-stroke patients follow up with their PCPs, most of the time they're with their families. And that's the right time to educate the families about the signs and symptoms of strokes, what to do if there is a recurrence of stroke.
So it's post-stroke. You're talking about
Post-stroke,
post-stroke. So one of the other things that Arnie Milstein brought to us from Stanford is this concept of outpatient intensive care. And so that would be, it could be post-stroke, but it could also be pre-stroke or pre-heart attack. And it could be used, for instance, in if there were some videos or something available where the doctors could prescribe that the videos are watched by the families, that could then be used for motivational interviewing for the patient to maybe change the behavior to lessen the likelihood that, for instance, that TIA is going to come in next as a full-blown stroke. So just as we think about action steps here, could we think about, say, a focus in the Sacramento area for those patients that you know need the outpatient intensive care?
So part of the CSC designation is to have an outpatient stroke TA clinic. So we are trying everybody who goes through our system to be seen by a vascular neurologist in this clinic. It's at San Juan. And we try to bring all these patients, stroke victims, to support groups. There is a lot of education in the support groups. And also, I don't know if you saw this acronym FAST, which has to be, it's everywhere plastered. For better, at this point, we emphasize this, and it's very well known to the population. But again, these high-risk patients, like you said, with AFib, with multiple risk factors, will have to be followed in a clinic. If they're in the Greater Sacramento area, we'll be seen there in our system. If not, we'll try to make appointments with them where they were transferred, Bay Area, Northern California, and so on.
community clinic setting, we're working on a lot of community health workers at the level of working both with the patient and with their families. Our organization has got a grant from the California Endowment to create a navigator training curriculum. It's an in-service training for navigators where to find resources to help their patients access those and understand and utilize them. And we're creating decision tree models around things like, all right, I'm a community health worker and my patient's got type 2 diabetes. They need to find food, they need exercise, whatever. A decision tree that helps them remember what to look for and gives them the resources to get them for the patient.
Yeah, I'd just like to bring up, I mean, we're talking about one very narrow sort of area of stroke prevention, not even prevention, it's detection and treatment. And we really focus more today on treatment than we usually do when I come here, and where we get into prevention some as well. But that raises two issues for me. One is, and I think this is, that some of you know the answer to this question, if we were to focus on those folks at particularly high risk, AFib, uncontrolled hypertension, et cetera, and try to get raise their families' awareness, would we really be getting to most of the first-time stroke victims? Or do we actually need a PSA that would involve, I think we probably have some public health folks here, some local public health, but is it really more educating the entire population, like the Be There campaign in San Diego, if that's the primary goal, is just to raise awareness? And then totally unrelated, as I listen to the panel up here, again, focusing more on sort of time to treatment, getting people in, I was wondering, how certain do we know that in Sacramento County, once they get to treatment, that they actually do get what they need, and that generally, you know, how widespread is the high quality that I think some of you represent for Sacramento County patients?
I don't know if you heard me saying about outcomes, right? So all of this, the Joint Commission or any organized Department of Health has to monitor the outcomes of any particular system, complication rate, what volume you have, and then they designate those centers as preferred places to go and have treatment for those patients. And this is done. We are collecting the data, and this is one of our stroke coordinators spend many hours gathering the data, analyzing, looking at trends. It's very time consuming. We offer this data to the EMS and to the Department of Health. Actually, I heard from you, I think, mentioning about Paul Coverdell registry. And California, finally, it's one of the 9 states in it. And why do I mention about this? Because Michael Frankel from Emory was one of the people who pioneered this registry. And I want to see more the resources behind Paul Coverdell registry applied to our practice here.
We have a question in the back.
I was actually just going to say something. I'm Rich Utley for Mercy General Stroke Coordinator. Part of the thing I believe that would help make people more aware of the high-risk stroke factors and everything, I don't see that we have a lot of community like health fairs or annual health checks or something like that. If we could provide something more, because a lot of people don't know they have stroke risk factors or heart risk factors until they have an event, and then they find out that they do have hypertension, they do find out they have high cholesterol or diabetes. So if we could do more health fairs and community events, I think that would help than just, you know, ads and other just literature.
Sure, just to kind of add on that, like something that that was mentioned at the beginning of this conversation was that there was a diverse group of minorities, especially in this area, the Sacramento area, that have had a higher incidence of stroke compared to the rest of California. And something that, at least at UC Davis, what we've been doing a lot of is exactly what he just mentioned, is we're attending local health fairs, almost on a monthly basis, providing education, screening patients. It's something that as a group, it's like through our different health centers, we could probably do more of to actually provide better education in regards to stroke prevention, which, like you mentioned, is actually, stroke is one of those diseases where it's probably one of the number one preventable disease that we have out there. Like outside of heart disease, like stroke is probably the number one preventable disease out there. So if you manage your risk factors well, you understand the disease, you're actually able to really prevent people from having strokes. So like, you know, like I said, like one of the things that UC Davis is trying to do more and more of is like actually reaching out to community to kind of like let them know, especially the ethnic communities, where education and communication in regards to health providers is not always ideal.
When we started the meeting, I asked the question that Arnie Milstein asked us all a few years ago at one of our summits, and I just want to know if anyone wants to offer a suggestion. His question was, if you were lying in a bed after having a stroke, unable to speak or move, what would you wish you would have done to improve stroke care? Anybody want to take that question? Dr. Ng.
Just, you know, like outside of acute care, which we've talked a lot about, like the one thing about stroke care, like I just mentioned, was it's the number one preventable like disease that we have out there. Like understanding that from like a baseline means that like if we as a group do a better job of taking care of the patients that we have out there in terms of managing their hypertension being a major risk factor, smoking, diabetes, and hyperlipidemia. Like all those things are things that are from a medical standpoint very preventable. And when you control those risk factors, you reduce the risk of stroke very significantly. So like, you know, from my standpoint, that's probably the number one thing. And then outside of that becomes the things that we do in terms of the acute care. When somebody actually has a stroke, what do we do from that standpoint? And I think we've done a lot in terms of talking about that.
I really appreciate that because as some of you who know me, I mean, I'm all about prevention. I have to admit I'm a physician who's been relatively uninterested in cure my whole life. I care about prevention. And we have 34 million people in this country with uncontrolled hypertension. So we would all do well to do a better job with hypertension, I think.
So we focused today almost primarily on treatment of acute stroke. And the reason is there's new information that has come out that has dramatically changed the landscape in that. The reality of what we're showing you today for treatments, number needed to treat to improve functional class is only 6. 6 patients you treat with this new therapy, and you're saving functional class in the meta-analysis for that. I mean, that's an extreme important, yeah, 4 in some trials, but in the meta-analysis it was 4 to 6 in the meta-analysis. So small numbers smaller than we see in a lot of therapies for medicine that we justify today. 3 to 6 people, and you're saving a significant functional life. Tremendously important and a real changer in the landscape. But the best way to treat stroke is, and always will be, prevention. Prevention of it occurring in the first place that starts you down that pathway for that. We know that lifestyle modifications are the way to do it. Reduction of blood pressure, cholesterol, other things that cause risk are there. And we know that in Sacramento County, for that, we're not doing a perfect job of prevention. We do not have high levels of compliance for achieving adequate blood pressure, achieving adequate cholesterol, reducing those risk factors for all of our individuals, including lifestyle modifications, diet and exercise, with those medicines. Now, if we look at the data in Sacramento, Kaiser does have a little bit better performance than some of the other healthcare systems. So I wondered if the Kaiser individual could comment about the success in Kaiser And is that applicable for the other health systems in Sacramento?
I don't know that there's any magic to it, so is it applicable? Yes. The way of going about it is